Can I start now?
Yeah.
Assalamualaikum everyone. Good evening. I'm Rifah Nanziba, currently studying biotechnology in BRAC University. And for today's presentation, I'm going to be presenting on the article titled Molecular Diagnosis of Huntington Disease in Portugal, Implications for Genetic Counseling and Clinical Practice. So Huntington's disease is a rare inherited neurodegenerative disorder, which is mostly autosomal dominant type disorder, which means that if if any of the parents are the carrier or have this disease, then the offsprings are also most likely to have this disease as well. It is caused by the mutation in the gene for a protein called Huntington, which causes the number of CAG repeats to be more than 36. So if the number of repeats is less than 36, then it's called normal. But if it is more than 36, then it causes the onset of the Huntington's disease. Now, based on the number of the CAG repeats, it can be classified into 4 classes. Class 1 with 6 to 26 CAG repeats, which is considered normal. Class 2 with 27 to 35 CAG repeats, which is expandable alleles, especially upon paternal transmission. Class 3 with 36 to 39 CAG repeats with reduced penetrance, which means that if a person has this number of repeats, then he or she might or might not have the onset of this disease. But in case of class 4, when if the number of CAG repeats is more than 40, which it is called fully penetrant allele, which means that he or she will for sure have this disease. Now, one of the main symptoms for HD is involuntary jerking or fidgety movement of the limbs and body, which is most known as chorea. But besides this, other symptoms can be difficulty concentrating and memory lapses, depression, stumbling and clumsiness, mood swings, personality changes, problems swallowing, speaking, breathing, and difficulty moving. So the aim of this article was at first to characterize clinical presentations, like to know the age at onset or to know the CAG number distribution and the geographic distribution of the disease in the Portuguese patients, besides to know the rate of positive molecular diagnosis, like how many patients are actually positive for this disease, and to identify the HD-like patients and families, like those who were not tested positive for this disease yet, but showed HD-like symptoms, or if there were any families or relatives who have this HD already. Then to assess the uptake of pre-symptomatic and prenatal testing, and lastly to identify cases that pose special problem for genetic counseling and their frequency. Now, moving on to the methodology, there are basically 3 parts to this testing. Firstly, the clinical diagnosis, which is like a confirmatory test for the patients who show HD-like symptoms. To perform this disease, signed informed consent forms were taken along with the clinical and family information with the demographic and clinical data to see if there were any family history of this disease. And most of the tests were done upon referral from physician, and it was from February 1998 to December 2002. Besides this, there were also pre-symptomatic testing and prenatal testing as well among the individuals who were not tested positive for HD yet, but they have family history or they are still showing symptoms of HD. A total of 338 samples were taken among individuals of the Portuguese origin, among which 96 were pre-symptomatic, 4 for prenatal testing, and 4 for performed for family studies. And the exclusion criteria for this test was non-Portuguese patients and families who tested for HD. So to know the number of CAG repeats to see if they were test positive for HD or not, at first blood sample were taken from the individuals, and from that blood lymphocyte genome DNA extraction was done, through which the CAG repeat was assessed through PCR analysis using RS1 and WP2 primers, which are the two forward and reverse primers. After that, the PCR products were run through gel electrophoresis to know the CAG repeat size. As for the positive controls, a patient with allele containing 94 CAGs and a patient with 17 and 40 CAGs were taken. Some problem were seen in case of homoallelism, which means that same number of CAG repeats in both the alleles. To tackle that problem, two steps were taken. Firstly, PCR was done using RS1 and RS2 primers instead of the WP2 primer we saw earlier. So these two primers contained both CAG and also CCG repeats. But if this did not work, then in that case, southern blotting was performed. And as for the statistical analysis, chi-square analysis tested different proportions by gender. Students' t-test was used to compare mean age at onset for referral in two groups, and the strength of linear correlation between age at onset and repeat size was calculated by R-square. Now moving on to the result part. Among all the diagnostic tests like for the confirmation of HD, 54.3% were female and 45.7% were male. In the general diagnosis for HD, it has been found that 64.5% were actually confirmed for HD, while 35.5% excluded individuals with HD. Now, if we look at the mean age, we can see that no differences were found in relation to age at referral, age at onset, or sex composition between patients genetically confirmed or excluded for HD. After the confirmation, few of the individuals were sent for request to confirmation and exclusion, like referral through physicians, mostly neurologists. So for confirmation, there were 169 requests. Yes. Among the 169 requests, it has been seen that 144 of the individuals were actually confirmed to have HD, while 29 of them showed false positive. And among those 29, 15 had family history of HD, 8 had no family history, while 6 were unknown due to not getting any information about their family history. Now, for exclusion, as 65 requests were given by the physicians, among those 65 requests, 54 were actually excluded. That means they did not have HD. And among the remaining 11, 5 had family history, 2 had typical symptoms of HD, and 4 had both family history and typical symptoms of HD. For the pre-symptomatic screening, 94 subjects were tested, among which 74 showed previous confirmation of HD in the family, 10 confirmed cases in relative, like a second-degree relative, and 12 tests did not have any previous genetic confirmation in a proband. And for the prenatal screening, it was seen that prior risk was found in case of 75% of the individuals if both the parents were carrier, 50% when one of the parents were affected or they were a carrier, and 25% when grandparent or other second-degree relative was affected. And the risk was unknown if the individual was HD confirmed, but no information on affected relative was found. In case of HD in families, as we know, it is an autosomal dominant disorder, which means it can be passed on from parents to offspring. So when HD was tested in case of families, it has been found that among the closest relatives who were affected, father was 46.3% of them, mother was 25.6% of them, sibling was 12.4% of them, and second degree relative was 4.1% of them, and cousins were 1.7% of them, which means the paternal transmission was more among the individuals. A test was also done to determine the CAG repeat length and the age of onset. An interesting thing can be noticed here is that among all the patients who were confirmed to have HD, 3 were infantile, 1 were juvenile cases, 68 were from the age range of 20 to 49, 32 were from 50 to 59, and 16 were from 60 to 73. So this indicates that even though the mutation in the gene is present in an individual from since birth, but the age of onset, like the appearance of the symptoms, have show up later in life. There were some special cases in case of counseling, like in homoallelism, as I talked about it earlier, homoallelism and homozygosity. It has been found that none of the patients were full homozygote, that is carrying fully two expanded alleles, but homozygosity was seen, that finding of large normal alleles, and homoallelism present difficult issues for genetic counseling. As for the individuals who were sent upon the request of physicians for confirmation or exclusion of HD, majority of the referral were actually confirmed to the test. Exclusion of HD in the remaining patients was able to be explained through their absent or unknown family history or by typical symptoms. In case of characterization of the patient population, it could be seen that even if the patients were tested positive for HD, but they did not have any family history, like in 5.3%, there were no family history found of this disease. So the one possible reason for this could be that new mutations of the intermediate alleles. Intermediate alleles were the class 2 alleles, which did not have which did not show the mutation for the disease, but new mutations could be a possible reason for the later onset of the disease. Greater involvement of women in family and reproductive decisions could be solved through pre-symptomatic testing and prenatal testing. So among the pre-symptomatic tests which were done, 7 belong to three siblings, actually like 3 groups of siblings, where it was found that one was a carrier, which proves that existence of the CAG expansion in the family, and one had the expansion, and 4 were non-carriers but had family history of HD but no proband tested. So this says that even if there were no symptoms, but they still had the expansion in their gene, which could prove that maybe they don't have the symptoms right now, but later in life, the symptoms could show. 2 homozygous individuals were identified. Now this homozygosity could create a problem in case for the counselor, because if the counselor needs to give an exact genotype, like is the genotype full, do they have full mutation, or are they fully mutated, and or one incomplete penetrance allele. But this also creates an ethical dilemma because the individual, it's their right to know the exact genotype, but also it kind of goes against the guideline. Now to conclude the presentation, since this study was not a population-based survey, so it's not possible to ascertain the number of patients and families, which so the unpredictability of age at onset and clinical prognosis in HD, for that accurate interpretation, proper psychological support, and sufficiently sound and compassionate communication is necessary. And to understand this disease better, how it develops, and why there is such a wide spectrum of heterogeneous clinical manifestation among patients, it is needed to, we need to constantly update the guideline and psychological support. Besides, genetic counselors can also help to make informed decisions by individuals. Thank you.
Thank you so much, Rifah Nanziba, for your excellent presentation. আপনাদের কারো যদি কোনো কোয়েশ্চেন থাকে প্লিজ আস্ক করতে পারেন। এই প্রেজেন্টেশন রিলেটেড কারো যদি কোনো কোয়েশ্চেন থাকে। Can you hear me?
Yes. So,
কারো যদি কোনো কোয়েশ্চেন থাকে প্লিজ আস্ক করতে পারেন।
Rifah, I had a question. Can you tell what is? Can you tell again what is proband? You mentioned it twice. Like proband.
Yeah, proband is basically the individual from whom we are considering the disease, the alleles have actually been spread. Like the allele of the disease. Like suppose from one of the grandparents, it was passed down to the parents, then to maybe the next generation.
Yeah. Thank you.
You're welcome.
Rifah Nanziba, ma'am, I had a question for you. Can you hear me?
Yeah, I can hear you.
Okay, so was it possible to take any other methodology than the one that was used for this diagnosis?
Yes, sequencing could have been done, but that would be very expensive.
Okay, thank you.
You're welcome.
আর কারো কোনো কোয়েশ্চেন? আপনাদের যদি কারো কোনো কোয়েশ্চেন না থাকে তাহলে আমরা আজকের প্রেজেন্টেশন শেষ করতে পারি।
No more questions for me.
Okay, thank you everyone. And again, thank you Rifah Nanziba for your excellent presentation. Thank you.
Thank you, everyone.